Good afternoon.
Thank you for hanging on. Hopefully my voice will too. So visceral leishmaniasis, or VL, also known as Kala-Azar, is a neglected tropical disease transmitted by a sandfly, which is characterized by fever, fatigue, enlarged liver and spleen, weight loss, and invasion of bone marrow, leading to leukopenia, anemia, and thrombocytopenia. It's a progressive disease with symptoms appearing 2 to 6 months after the bite, and without treatment, it's almost always fatal within 2 years. So Ethiopia bears a high proportion of the global burden of VL. VL is both endemic and epidemic prone in Ethiopia, particularly in the northwest region. And this is also where there's an annual migration of hundreds of thousands of mobile seasonal workers. So CALICOR is an international consortium of organizations that are working to control and eliminate VL in 6 countries, including in Ethiopia. They have 4 technical partners, which are the London School of Hygiene and Tropical Medicine, the Drugs for Neglected Diseases Initiative, Médecins Sans Frontières, and Mott MacDonald. And the key activities of CALICOR include training healthcare workers, surveillance, case management, and health education. So there's currently insufficient knowledge on VL, particularly related to the populations that are the most affected and barriers to VL diagnosis and care. So we were asked by CALICOR to conduct research on VL in Ethiopia to inform their activities and their interventions. The objectives of our research were to identify and describe barriers to access to VL diagnosis and care, to understand the reasons for these barriers, and to provide recommendations to improve access to VL diagnosis and care. We conducted our study in early 2017. It was a qualitative study that involved 50 in-depth interviews and 11 focus group discussions. So it's not clear who is most vulnerable to VL. We know that mobile seasonal workers have a lot of risk factors, but residents are also considered to be important. So we recruited different types of participants, and these participants were adults that came from the following categories: so current and previous VL patients, caretakers of VL patients, healthy mobile seasonal workers, community members and leaders, and health staff. So during our in-depth interviews, numerous participants stated that malaria is converted to typhoid, and finally the disease becomes VL. So this concept of disease evolution may be related to the various steps that were required to access diagnosis. I will next present a case study to illustrate this point, and this case study is representative of many participants and was repeated throughout the study by multiple individuals. So participants presented with 2 symptoms, fever and severe headache, for which they went to a private pharmacy. And at the private pharmacy, they received paracetamol. Unfortunately, their condition continued to worsen, and they next presented with a 3rd symptom, that of splenomegaly. For this, they went to a health center, where they received malaria treatment. They didn't improve. They went back to the same health center, and there they received treatment for typhoid. And I think it's important to mention that the clinical guidelines in Ethiopia recommend considering VL among patients with at least 2 weeks of fever who are not responding to anti-malarials. For some, but not all participants, they next went to a traditional healer, where they received smoking of leaves or holy water as an intervention. As they continued to deteriorate, this time now presenting with weight loss as a 4th symptom. Those who had access to money went to a private health clinic where they received treatment for pneumonia. Participants next experienced hemorrhaging, and at this point, thanks to encouragement from peers, family members, farm owners, or referral from a healthcare worker, participants went to the hospital where a diagnosis of VL was finally established. So from this case study, I think you can see that there were multiple visits that were consistently needed in order to access VL diagnosis. Social support was strongly influenced by health-seeking behavior and care, and by social support I mean money and advice from family and peers, caretakers, and healthcare workers. And interestingly, health-seeking steps were very similar for the mobile seasonal workers and the residents, and this may be because they were both poor, and many residents also engaged in mobile work. So risk factors that were specific to mobile seasonal workers prior to admission were having lower income, labor constraints, and if returning home to a non-endemic area, the unavailability of diagnosis and treatment. And at mission, the total loss of income and lack of a caregiver. So a participant stated, "I was borrowing money from my brothers and other relatives to pay for a bed to buy syringes." Another stated, "Since they are mobile workers without caretakers to help take extra food, they might be forced to quit the treatment because of inadequacy of food." So one positive finding from our research was that there were few delays starting VL treatment once diagnosis was established. And in fact, in accordance with the national policy, diagnostic kits and treatment are free and available at hospitals. However, care is not free. There were high expenses prior to VL diagnosis, and patients had to pay for the associated costs, such as for syringes, a bed, a health card, additional food, and treatment for various co-infections. In addition, they had a loss of income during their hospital stay, which on average was 1 month in duration. So while the health policy for VL is good on paper, in practice, it is striking that in a VL endemic setting, access to diagnosis was very poor and access to treatment was consequently delayed. So there are numerous recommendations that may help to reduce delays to access to diagnosis. These include decentralization of rapid diagnostic test kits to the primary healthcare level, training of healthcare workers, practical health education for the community that would be focused on when to suspect VL and where to go for VL diagnosis and care. And this would be rather than having health education that's merely focused on transmission and prevention. Additionally, monitoring and evaluation of healthcare service delivery may help, including referral and flow of patient information, healthcare provision at or near the farms, and enforcement of VL protective measures and referrals from the farms. We also recommend that to improve access to treatment, that we offer free comprehensive healthcare for VL patients. So in conclusion, I would like to thank the authorities who allowed us to conduct the study, our collaborating partners and study team, and all study participants. Thank you.